Everyone. So welcome back once again. This will be the last foray of systemic pathology. Zain, I generally focus on forays on things which are more important. I'll try to definitely incorporate skin and endocrine and bone and some other extra additional classes if we have. And CVS definitely I've covered in the first chapter, first one on systemic pathology. That was on last Friday, right? Just go and have a look at that, right? Good afternoon, guys. Good afternoon, Kalpana. And I hope, sorry for preponing it by 2 hours because that wanted to have a commitment around 5. That's it. So what we're going to do today is we're going to talk about FGT and breast parenchyma. Coming from a university point of view, female genital tract is not something which is very important. They might not ask a long answer. Yes, short answers are very much possible to come because you will be reading lots and lots about female genital tract when you come to gynecology because including the microscopic features, you will revisit them when you go to gynecology. But breast parenchyma, there is a very likely chance that breast cancers can come in a long answer because it's very well suited for a long answer question. A superb classical clinical scenario, microscopy, pathogenesis, sporadic inherited risk factors, and the different variants and also markers, right? So with that note, let's go ahead. As usual, I'll be starting the class with few questions. I want you guys to comment on the answers and then let's see how we can take it from there, fine? So now, first and the foremost thing, someone asked me yesterday to talk about penile cancer. Penile cancer and cervical cancer, the pathogenesis etiology is almost the same. Gross microscope is almost the same. The only difference is clinical features, that's all, right? Can anyone tell me what is the first etiology which comes to your mind when you think of cervical cancer? What do you think of cervical cancer? The first pathogenesis etiological features comes to your mind. I'm sure you know about that. Lots of vaccination drives are going around that and my country is pushing towards that. That's your HPV, right? HPV by default is the most common cause of cervical cancers. With vaccination, it is reducing by default and over the period of time, hopefully it will reduce to a bare minimum, right? Can anyone tell me or name one screening test which can be used to pick up cervical cancers? The name of the screening test is more than enough for me. The third question, in the screening test or in the biopsy, if I have to say, okay, this is the finding for HPV infection, what is the finding? What's the finding? That's perfect. Your coilocytic atypia, right? So with that note, we'll go and look at the first topic of today, that is cervical cancer. I'm zooming in here. Let's go to it. See, when you look at HPV vaccination, HPV virus is not the only thing which is going to cause cervical cancer. It is going to cause, other than cervical cancer, almost every anogenital lesion. That's why I said the penile cancer, the etiopathogenesis is one and the same. The only thing difference is the clinical features. That's all, right? So Pap smear is the cervical screening test which will help us to have an early diagnosis, and immunization by default will reduce the incidence of cervical cancer. If they ask a reasoning why question, why does the incidence of cervical cancer reduces? These are the two important changes: an early detection by Pap smear and treatment, and HPV vaccination, which removes one of the major etiology. Along with HPV, there are few associated findings. One of them is smoking and alcohol, because what it does is it kind of reduces the immunity locally. So when the immunity reduces, a virus can stay for a longer time. Right, any viral infection is a short-lived thing. Only when they stay for a longer time, it will obviously result in the cancer pathogenesis, and it can automatically alter the DNA of the cervical epithelium, right? And these are all risk factors which is associated with increased risk of HPV. That's all. Multiple sexual partners, sexual intercourse at the young age, right? And most important thing, HPV is one thing which can transmit via skin to skin contact. So barrier contraceptives will not provide 100% protection like it might do it for HIV infection, right? High parity again is pointing towards that, again, men having more sexual partners, and that can transmit to the women by default, right? And insufficient immune response. This is the most important contributing factor because this increases the longevity of the virus inside the cell. That is very, very, very important, right? Only when the virus lives for a very long time inside the cell, the virus can cause DNA changes, and causing DNA changes is the only way it can induce cancer formation, right? And there are two groups or two serotypes of virus. We divide them into low-risk HPV phenotypes and high-risk HPV phenotypes, right? I'm just going to pull this down and I want you to tell me what are the genotypes which are low risk. Like there are numbers, right? 1, 2, 3, 4, which are low-risk HPV virus, which do cause problems like wart, genital wart, condyloma. They don't cause cancers. They are 6 and 11. And the high risk HPV phenotypes are 16 and 17 are the most common one. Apart from that, we have 31, 33, and multiple other high-risk phenotypes, right? You have to remember this because most of the vaccinations are concentrating on the high-risk phenotypes and not the low-risk ones, because low-risk ones causes genital warts, which is treatable, which is curable, nothing much important for us, right? Both of these, be it low risk or be it high risk, has two important viral proteins can definitely come in a viva. These I'm sure you know them as well. These are viral proteins E6 and E7. E6 destroys the host P53. P53 is a guardian agent, right? It will destroy them. And your E7 will nullify retinoblastoma. Both of them are very powerful tumor suppressors, and these viruses E6, E7 is going to modify them. And the most important difference here, right? Good evening, good afternoon, Mariam. The most important difference here is this low risk HPV virus will also have the same E6, E7. High risk HPV virus will also have the same E6, E7, right? So the pathogenesis changes like this. Low risk is always in the episomal form. They are not integrated into the DNA. They're just above the DNA, right? So they impact the DNA of the host, but indirect impaction. So when the cell divides, the episomal form may be with the cell or it can disappear, right? Because cell divides into two parts. One of the cell might not even have that, right? So they do not integrate into the cell, DNA. So with cell division, episomal part or the effect multiplies, divides by half. So that's the reason they are not very virulent. This is important, especially if you're writing cervical cancer pathogenesis. I want you to focus only on this. If the question comes on 5 mark on genital warts, same etiology, same risk factor, the pathogenesis is different, it is in the episomal form. In a high-risk HPV genotype, they are be the integrated form. What does it mean? It will go and bind with the human DNA. So once the viral DNA integrates into the host DNA, it will have a persistent infection. In spite of having an amazing immunity, whenever the cell divides, the virus also divides because the DNA are twined, right? So here it is integrated into the human DNA. So there will be a persistent infection and a persistent production of E6 and E7 with every cell division. And with every cell division, that's where we have the problem of mutation also, right? It will nullify P53, nullify retinoblastoma, and increase risk of cancer. In other words, increase risk of uncontrolled cell division, which results in cancer. This is very important for you to know the way of pathogenesis of low-risk HPV phenotypes and high-risk HPV genotypes. Fine? Perfect. Now, if you look at the spectrum of disease, we know the etiology, we know the pathogenesis, we have to know what will it do to the cervical epithelium, right? So we have a spectrum. Previously, if your examiner wants still the older classification, which is not used anywhere, we call it CIN, cervical intraepithelial lesion. There are 3 stages or subtypes, CIN 1, 2 and 3. Can anyone tell me the other name of CIN 3? That is carcinoma in situ. Like you can see in the image below, you have dysplasia in the lower 1/3. You have dysplasia in the lower 2/3. The dark ones are the dysplastic ones, right? And CIN3 is the entire thickness is involved. It's the complete involvement of the epithelium, but it's in situ, which means what has not happened? There is no basement membrane breach. Fine. Obviously, Anu, this is just a revision close to the exam. That's all, right? So we have carcinoma in situ, which is not involve the basement membrane. It will not go below the basement membrane. It will just remain above the basement membrane. That is the older classification. What was the problem with this? If I report CIN2, the gynecologists don't know whether to treat it conservatively with medical management or to do surgery. It's the cat on the wall report. So that's the reason we changed to a newer classification called as SILS, squamous intraepithelial lesion, right? Low grade is LSIL, treated conservatively, wait and watch, repeat the test, don't do a surgery. High grade is irreversible. This encompasses both CIN2 and CIN3. So now we have taken a call, it's fine. Let's put CIN2 also as bad. Let's not keep it cat on the wall. Both of them are qualified as HSIL and the lower one is called as LSIL. This is the latest classification which is applied in pap smear, which is applied in biopsy anywhere, right? So like I said, in biopsy, if I see this finding, coilocytosis, again a question, I'll pull this down. A question for you guys, I want everyone to answer. When I say coilocytic atypia seen, do I mean this patient has cancer or do I mean this patient has HPV infection? What do you get from that? When there's a coilocytic atypia, what do you mean by that? It means the patient has only HPV infection and not cancer. This is an evidence of HPV infection, that's all. It doesn't mean it can be seen in cancer, but it doesn't mean this is equivalent to cancer. For me to call something as malignant, I need dysplasia features. Coilocytosis is an evidence of HPV infection. That's all. Fine. Okay. So here we have what we'll find in microscopies are lots of clear intracytoplasmic inclusion and a shrunken and a condensed raisin-like, like a Christmas, right? The dry grapes, like that. A raisinoid nuclei, a shrunken nuclei, clear intracytoplasmic inclusion is called as coilocytosis. Coilo means hollow. It's an empty space. Fine. Okay. Perfect. So we know what to look in the progression of the disease from CAN1 to 2 to 3, then obviously into invasion, right? Now, so once we know that, we obviously are going to go to your patient characteristic features. Will be above 40-50 years only, right? It's not going to be seen in younger individual. Most of the time above 40-50 years. Fine. So above 40-50 years, and there is history of post-coital bleeding. This is a very, very, very classical finding, because imagine there is such a high-grade lesion in the cervical epithelium. So when there's in sexual intercourse, obviously it will induce trauma and there'll be a bleeding there. That's a classical post-coital bleeding, is suggestive of cervical cancers. And the most common cancer in cervix is by default squamous cell carcinoma. Adeno is very less, neuroendocrine is even more lesser, right? It's predominantly 90% and above is pure squamous cell carcinoma. The feature I'm going to tell you, you're going to use it for every squamous cell carcinoma throughout the body. You will have a pearly white lesion and it will be ulceroproliferative. Fine. Anurag, I think I've done that in the CVS chapter. The notes will be there. Just go and have a look at that once. Okay. So you'll have ulceroproliferative lesions. Okay. Plus it will be pearly white. Pearly white ulceroproliferative lesions on gross is good for esophageal, lung, skin, cervical, penile, vulval, vaginal, any squamous cell carcinoma. It will not change at all. That's by default the same. If it's adenocarcinoma, you can say that you can see some mucinous glistening areas, because mucin will be there. It might be glistening by default, right? And microscopy, again, 90-95% of them are squamous cell carcinomas only. Adenocarcinoma can also happen. Adenocarcinoma, you know what you'll have? The pattern is glandular pattern. Can anyone tell me the pattern for squamous cell carcinoma? We've been reading a lot of pathology. This is the bare minimum you have to know. That is, it's written there as well. That's your classical keratin pearl, right? You will see keratin pearl. If I see keratin pearl, I call it a keratinizing variant of squamous cell carcinoma. Sometimes there's a possibility I might not see keratin pearl. That is a non-keratinizing variant of squamous cell carcinoma. Fine. Raviraj, I won't call them a same. Neuroendocrine tumor is a spectrum. In that, carcinoid is a subtype. Atypical carcinoid, small cell carcinoma. The same way what we saw in lung, right? Neuroendocrine is the umbrella term. Under that, carcinoid comes there. Fine. Okay. Perfect. And here, glands will be there and there'll be invasion. Both of them will have the same 4 features of dysplasia, which you cannot ignore. High NC ratio, pleomorphism, your loss of polarity, and mitotic figures. That will be there across every cancer. And this marker is again the best marker across squamous cell carcinoma in the body, right? P63 and P40. For adenocarcinoma of the cervix, CA will be positive, okay? And the most important thing is, I have one more marker called as P16. This can come in an MCQ or Viva. What is the evidence that this cancer is due to HPV? If I don't see coilocytic atypia, what is the evidence? Because virus caused the problem. After that, it became a cancer. Once it became a cancer, virus might not survive. I may not see them often, right? If I don't see them, I use a marker called as P16. If P16 is positive, the only interpretation here is that the cancer is due to HPV virus. Is HPV related carcinogenesis? That's a very good marker to identify HPV related carcinogenesis. And WHO has made it mandatory to report oral, oropharyngeal, nasopharyngeal cancers of the anal genital tract to have P16. That will help us to know what is the amount of cancers related to HPV, which will help us predict, if I give vaccination, how many cancers I can prevent. That's how science grows by default. Fine. CA is carcinoembryonic antigen. Okay. That is a mucin marker. Remember like that. It's a carcinoembryonic antigen. It's a mucin marker. Fine. Perfect. And by default, screen is 2 parts. Pap smear is the basic way to screen. I look at you, what is the instrument used to do pap smear? I'm sure you know that. We have an instrument called as IR spatula. It's one of the pathology spotters which you might get in your practicals. Using the IR spatula, you take the mucin out of it, or a cervical brush or a cervical broom, and then you put it on a slide. Under the slide, I'll be able to say it's good, it's dysplastic or malignant, and then give a report for that. Fine. Okay. Hi Daisy, good afternoon. And genetic testing. Genetic testing has become almost mandatory in every place where they can afford, because just telling HPV, just telling coilocytosis does not give me the confidence it is low risk or high risk, right? Okay. Sure, Raviraj, I'll do it. Fine. So what we'll do here is, this will increase that, it will differentiate them with low risk and high risk, and the test name is hybrid capture. It's a PCR based test. We use something called hybrid capture. I give this pap smear sample to the lab will tell HPV present or not. Not just that, it will tell it as high risk HPV or a low risk HPV. That's something which is very important here. Fine. Okay. You guys want exfoliation cytology. I'll do one thing. I'll just take an extra space and write a few things for exfoliation cytology, because I have not made the proper notes for exfoliation cytology. Fine. Okay. See, exfoliation cytology is a very simple term. As a term says, it's exfoliation, right? You scrub, you must be using beauty products, right? And you follow lots of Instagram influencers who say that you can exfoliate skin with a lot of them, because dead cells will automatically fall out of the body. That's called as exfoliation, right? So what I'm doing in exfoliation cytology is, I am not actively taking a part of the body. What I'm doing is, the cells are already shed and I'm looking into that. That is what is called as an exfoliation. As simple as that, right? So in exfoliation, these are already shed cells which are looked under the microscopy for diagnosis. I'm using short forms so that we can scribble faster. That's it. Fine. It's just dead cells. I'm looking at them in microscope. Make sure that I will not be, I can use them for diagnosis. So where all these cells can come? It is not only pap smear. Pap smear is an example of exfoliation cytology. Have you heard about something called as BAL, bronchoalveolar lavage? In microbiology, you might have heard about that for tuberculosis, right? That's shed cells. I don't go and poke the bronchus. I put a saline, wash it, and take it outside. Sputum, right? Charcot-Leyden crystals, Kirschmann spirals. I don't go and prick the throat and take sputum. It's automatically shed. In your 6th standard or in school days, have you looked at buccal smears? You rub the buccal mucosa, that's also there, right? So I have lots of examples. One of the most prominent examples is pap smear. We have something called Jank smear. Jank smear is a buccal mucosa testing, what I said. It's a buccal smear. Or it can be touch smear on any skin ulcers, right? You have bronchoalveolar lavage. You have sputum cytology. You have urine cytology. See, all this, I don't do any effort. I am looking at the cells which are already shed. That's why the reason exfoliation cytology. It's also a screening test. It is not diagnostic, right? So I know what is exfoliation cytology means. I know a few examples of them. So what we do here is, the way exfoliation cytology is done, right? The steps of the procedure, if you want to name it, right? The first, if I take a smear, I just make a smear. But urine and BAL are good amount of volume. Without centrifuging, I won't get good amount of cells, right? So either you make a smear directly, like in pap smear, you can make a smear directly, or in Jank smear, you make a smear directly, or you centrifuge the specimen. Once you centrifuge the specimen, the sediment will have the shed cells, right? And that is made into a smear. After making a smear, we generally do 2 stains, pap stain. If it's pap smear, I prefer only pap stain. If it's Jank smear, if it's BAL, if it's sputum, I do pap smear, as well as I do GIMSA, MGG or GIMSA stain. Okay. Hi Rudra, hopefully you will get soon better. Please consult a gastroenterologist and listen to the advice carefully. Fine. So once I do a pap smear and an MGG, May Grundwald GIMSA or GIMSA stain, then we can look into the microscope for abnormalities. So next is, what are my clinical use cases? I am sure you can write at least few use cases for pap smear. Can anyone tell me any use of pap smear apart from screening of cancer? I will write that. Screening of cancer, definitely I can write that. screening of cervical cancer. There are a few more use cases as well. At least one, let me know. Second, what's the use of Zhang smear? Zhang smear is one of the classical places where we can use it to diagnose herpes infection. So when I say herpes infection is very simple. It has a tiny blister in the oral cavity. So you just press on them, look at the liquid, look for herpes changes. And the classical herpes changes are 3M. You'll have margination of the nuclear chromatin. You'll have molding of the nucleus. Molding means one goes into the other, that is molding of the nucleus, and there'll be multinucleation of the nucleus. That's a classical finding for herpes. I can use it for any herpes ulcer, be it a genital ulcer or be it a oral ulcer. You guys didn't answer this. The second use case of pap smear is to identify genital infections. Can you diagnose genital infections? You can, right? Remember the clue cell for Gardnerella vaginalis, right? Candida I can identify, right? Chlamydia you can identify, your trichomonas you can identify. You can easily identify genital infections and diagnose genital infections, right? Next, your sputum cytology. Sputum, very rarely you can use it for cancer screening, especially if you have a cancer in the in your trachea, squamous cell carcinoma, neuroendocrine. It can come outside while you spit, but the sensitivity and specificity is extremely low, right? And BAL also can be for cancer. Apart from that, it can be for infection, right? Infections, tuberculosis, where the sputum is not able to get the bacteria, you use a BAL fluid, wash them, clear them, and you can see them, right? And last but not least case, urine cytology. Urine cytology, again, I can pick up few infections, might be useful, and one cancer. Can anyone tell me what cancer will shed into the urine? I will leave it to you, right? Tell me whatever comes to your mind, what cancer cells will shed into the urine. That is bladder carcinoma, because the urine stays in the bladder for quite some time, and if there's a bladder cancer, it might shed and we can look into it, right? Bladder cancer, the cells can shed into the urine and I can look into the microscopy and give a diagnosis, right? So this should be enough, right? Raviraj and DC. A subtle way to write what is exfoliation cytology means: write a definition, write in your own words whatever comes to your mind, give examples, put the procedure how it's done, and a use case. If you want, do few diagrams of pap smear and maybe elaborate a pap smear a little bit more. Fine? Done? Okay, perfect. Now let's go to next question. Next question you're going to talk about is endometriosis. Again, few questions to you. I want you to answer, then we'll take it from there. Can anyone tell me any one theory at least what you remember regarding endometriosis? There are multiple theories of endometriosis, right? Most welcome, Raviraj. Math magic, we'll see it later. If you're starting second year, we'll do it later. You know multiple theories for endometriosis, right? At least one theory. There's a common theory called regurgitation theory, right? Perfect. Retrograde menstruation or regurgitation, right? Perfect. So endometriosis, reverse menstruation, retrograde, everything means one and the same, and that's one of the most accepted theory, right? This is something which is bare minimum I want you to know. Stem cell is the latest theory. If you say that, that also is amazing. First, we look at the definition of endometriosis. If you see endometrial tissue, the most important thing most of the people misses, they will call it endometrial glands. It's not glands, it is both. If only gland is there, I cannot call it endometriosis. It should be endometrial glands and endometrial stroma. If both are there outside the uterine cavity, even if it's in the tubes, it's abnormal for me. Normally, endometrium should be there in the uterine cavity. Anything outside the uterine cavity, I use the term endometriosis. If it goes into the myometrium, can anyone tell me what do we call them? If there's an endometrial glands and stroma deep into the myometrium, we call it something else, right? I'm sure you know the name, right? There are theories. Theories are nothing but the pathogenesis. How did it go there? The easiest one and the widely accepted one is regurgitation theory or a retrograde menstruation. Normal menstruation, the blood flows outside, right? External genitalia and is wasted. In retrograde menstruation, whenever the blood flows outside, little bit of it can regurgitate through the fallopian tubule and can go to the ovary, cul-de-sac and all the places. Fine. We call them adenomyosis, right, Deepita? I'm sure you know that. I think endometriosis, you related to myometriosis, we call them adenomyosis, right? Perfect. So here, that's how it is. It just regurgitates. So it can be in the tubes, it can be in the ovary, it can be in the peritoneal space, it can be in the cul-de-sac, in every place, right? Perfect. It can be in all these places, right? 60% of the endometriosis which happens in the ovary can be easily explained by this. Tubes, common place. Endometriosis, these are common places. But will it be possible for me to explain with this theory endometriosis in lung? No, I can't. Endometriosis in colon? No, I can't. So that's why there's a requirement for other theories. Then we said that, okay, benign metastasis. During menstruation, you must have heard about spiral arterioles. They will break and then only endometrium will shed. So they say that while breaking and shedding, there is a possibility some of them can enter the blood circulation. If it enters blood circulation, tiny fragments go to a different part of the body and they can settle there. That is benign metastatic theory. Mets is nothing but traveling via blood circulation for malignancy, but it's a benign condition which can also metastasize. Then we came up with coelomic metaplasia. When my squamous can become columnar in my esophagus, obviously any coelomic epithelium, there's a possibility it can become endometrial gland, right? So there's coelomic metaplasia in the peritoneum. I can have peritoneal lining becoming endometrial gland. That also is a plausible theory why I have endometriosis in my peritoneal area. But the latest one, which is most accepted, is your extrauterine stem cell progenitor theory. Now we know that every organ in my body has stem cells. Like my bone marrow has the most potent stem cells, right? Obviously most potent stem cells. So stem cells in the bone marrow can give rise to anything in the body, from brain to the tip of the toe. Like that, I have extrauterine, there are lots of progenitors. Multiple organs as stem cells. So those stem cells, instead of giving lungs, in lung, if it gives rise to your endometrium, that's my stem cell progenitor. Okay? Yes, Shrikant, you can. And for liver, it can explain. But this gave actually one more insight. When it's stem cell involved, stem cell is changing from one to another. So which means there might be a possibility mutation can happen. Whenever I touch stem cell, I always have a problem. There is a possibility for us to become cancerous. Stem cell progenitor theory said that it's not just the stem cell change. Actually, the endometrial tissue formed is not normal. They have more pro-inflammatory cytokines than a normal endometrium, like your interleukins, TNF and everything, right? They increase estrogen production compared to a normal endometrium. So they're not just in wrong sites, they're also different. And they also have few mutations. One of the common mutations which is seen is ARID1A. Okay, if you can remember ARID1A, write ARID1A, otherwise just write. There are mutations also noticed. And they also say that ovarian endometriosis is a precursor for endometrioid ovarian and clear cell ovarian carcinoma. So it's not just the endometrial tissue seen outside somewhere. The stem cell is involving, mutations are there. That is the reason they go outside and become ovarian stem cells become endometrial glands. So there's a risk of endometrioid cancer and clear cell carcinoma in the ovary, right? This is proven and this is a latest theory, right? Regurgitation, metastasis, metaplastic and stem cell progenitor theory, right? Now sites and clinical features go hand in hand. Most common site is ovary and we call them chocolate cysts in the ovary, because every time in this menstruation these glands and stroma will shed and they'll form again, will shed and they'll form again. So all of them sheds inside the ovary and becomes a red color, brown color fluid we call the chocolate cyst. Simplest clinical feature, intense dysmenorrhea. Whenever there's menstruation, ovary cells also die and shed, but they cannot go outside. So there'll be intense pain in this patient. Uterine ligaments, almost same. Rectovaginal spectrum, almost same. Cul-de-sac, almost same. It'll all be in the pelvic area, right? You'll have an intense crampy dysmenorrhea. That's how it presents. If there's in lungs, they might spit out blood, cyclical. Whenever there's a endometrial cycle for the women, the lung endometriosis also will die because they are also hormonally responsive. They also will shed blood and that will come out in the blood, in the sputum, hemoptysis. Colon, dysenteries or hematochezia. You'll have fresh blood in the colon based on the location of the colon you'll have, right? Bone, again intense pain. They are very rare, but again intense pain. Scar endometriosis, again intense pain in the scar, endometrial scar. If it's visibly seen outside, you can see a lump which is reddish to brownish in color. Fine. Okay. So this is how endometriosis patient presents with. It's classically based on the location because this is a hormonally active tissue. How do I diagnose? How do I confirm? The best way to diagnose is look at them and take a biopsy and see. Most common is ovarian endometriosis. You do a diagnostic laparoscopy, you see punctate areas of hemorrhages. You'll have like your flea-bitten kidney, what we saw, I'll have multiple tiny brownish spots on the surface of the ovary, classical for endometriosis. After you excise the ovary, what I see them in microscopy is, I'll have the endometrial glands plus endometrial stroma, and this stroma is positive for CD10. That's a very easy way to know it's an endometrial stroma and not something else, right? That's what I see in biopsy. I see endometrial glands and stroma in different organs, in the colon or in the lung and in different places. Fine. Okay. Next is adenomyosis. Adenomyosis is simple. The stroma and the glands are going deep into the myometrium. We call it adenomyosis, right? It's not. They don't have any classical theories here. It's commonly seen in middle-aged women, and this also will be associated with dysmenorrhea. Imagine the glands and stroma is bleeding inside the uterine wall. It will obviously cause intense pain, right? So how do I diagnose them? Let's say, see, this is a way you have to draw the image. First, kind of draw endomyometrial junction. Okay, that's a junction. If you see glands in low power field, 2 to 3 millimeter below the junction, you can write this as 2 to 3 millimeter below the junction. I do see glands, that is adenomyosis. Or one low power field below, I see it's adenomyosis, right? So how depth is also important, right? If I have glands here, I don't call it adenomyosis. It has to be 2 to 3 millimeter below the endomyometrial junction. Then I can call it, yes, this is deep enough for me to call it an adenomyosis, right? And the treatment for adenomyosis, you'll read in gynecology, it's still hysterectomy. If the family is done, if the mother has given birth to kids and there's no further kids down in the lane, remove the uterus. That's the only way you can do. Nothing else can be done. If the family is still going to be there, yes, there will be dysmenorrhea and there will be symptomatic treatment there. Fine. That's about your endometriosis and adenomyosis. There's a likely chance that you can have a short note on endometriosis and adenomyosis. Fine. Okay. Now let's go to the next question, which is endometrial cancer. Again, same examples. Few questions. Can anyone tell me what are the types of endometrial cancer you know? Whatever comes to your mind. Any types of endometrial cancer you know? There's a way we used to classify it previously, and there's a way we classify it now. We used to classify them into type 1 and type 2, type A, type B endometrial carcinomas. One is like classically seen in your reproductive age group, one is seen postmenopausal. And there's also a new molecular classification. I'll talk about both of them. If your university is more inclined to ask advances, please remember molecular classification. Robbins has that, your CBME curriculum has that, and in real life it has been followed for the past 4-5 years. So you have to know the molecular classification of endometrial cancer as well. Fine. Okay. Type 1, type 2 is the old one, and we'll definitely look at that also. Okay, done. So we have two types of cancer, type 1 and type 2. One is said to be in the reproductive age group, estrogen dependent, that is type 1. The second is non-estrogen dependent, non-endometrioid, and seen in postmenopausal age group. Fine. So first one, you have unopposed estrogen here, and you have all these guys. That's metabolic syndrome X. The primary problem here, you must have read about the PCOS becoming PMOS. There's a metabolic irregularity which is resulting in hyperestrogenism, systemic inflammation, infertility, hypertension, diabetes, obesity. The single metabolic problem, right? So that is going to result in excess amount of estrogen than normal. What will estrogen do to endometrium? Estrogen causes hyperplasia, that's all. So initially there will be a simple endometrial hyperplasia. Over the period of time, it will become an atypical endometrial hyperplasia because more and more glands become hyperplastic. There's a chance of new mutations coming there. And one of the important mutation here is PTEN. When PTEN is inactivated, this is the most common mutation in endometrial cancers. I want you to know. It will become carcinomatous, which will range from well to poorly differentiated, right? There's a simple pathogenesis of type 1 endometrial cancer. So what will happen to type 2? That is non-estrogen dependent, and that happens in post-menopausal age group. So in post-menopausal age group, there is no estrogen, there is no hormone at all. The endometrium is atrophied, right? So what happens is this primarily is due to mutation. So in an atrophic endometrium, if the person is exposed to radiation or some kind of carcinogenesis, which is going to cause mutation, and the mutations, this is one, and BRCA is also associated. Okay. Nulliparity, see, nulliparity might be more in favor of your breast cancers. Yes, endometrial cancer also to some extent, but not very often, right? Okay. But yes, that also will cause hyperestrogenism. Fine. So when you have T53 mutation, a normal atrophic endometrium becomes something called serous endometrial intraepithelial carcinoma. That's the first step. Instead of having endometrial hyperplasia and carcinoma, here from normal becomes an endometrial intraepithelial neoplasm or carcinoma, that is serous type, and then with more mutation, it becomes malignancies. When it becomes malignancy, there are 3 types of malignancy which is common in type 2. These are all microscopic subtypes. If you look at this, it is endometrioid adenocarcinoma. That's a microscopic subtype. I divide them into type 1, type 2. That is based on the pathogenesis. But microscopy, type 1 can be endometrioid only, and type 2 can be serous. Whenever it's serous, what will come to your mind? What's the microscopic finding? Papillae plus amoma bodies. Clear cell and carcinosarcoma, mix of carcinoma and sarcoma, right? So all these are the microscopic subtypes of type 2 endometrioid tumors, right? Now let's look at type 1 microscopy first. Endometrioid adenocarcinoma. Endometrioid looks like endometrium, which means is a simple normal adenocarcinoma. What's the pattern? Glandular pattern? Same. You'll have glandular pattern. You'll have your 4 feet of dysplasia. You'll have invasion, but invasion goes into the myometrium, right? And there are variable differentiation, like I said, from well differentiated to poorly differentiated. Fully 100% well-formed glands, what do you call? Well or poorly differentiated? It's extremely well differentiated, right? Like 10% glands, rest of them are solid area, poorly differentiated, right? So well to poorly differentiated is based on the morphology, right? And there's a finding called squamous morules. We'll have nest of squamous metaplastic like epithelium, which is same. Type 1 has to be ERPR positive because they are hormonally dependent cancers. That's very important. None of the type 2 will be ERPR positive. It will be variable or they will be negative. Okay, because they are not estrogen dependent. Fine. In type 2, we have papillae, samoma bodies because they are serous type. Anything serous, we call them serous adenocarcinoma of the endometrium. Papillae, samoma bodies, very pleomorphic. Obviously bad one, right? P53 positive and P53 positive. Clear cell, as the name says, microscopy cells will have clear cytoplasm. That's why we named it clear cell, right? And mixed Mullerian tumor, the newer name is carcinosarcoma, which means I'll have carcinoma, epithelial malignancy, and sarcoma, mesenchymal malignancy. We call it carcinosarcoma. Okay. So what do you think? Which of these two do you think will have better prognosis? Something which happens a little bit early in life, ERPR positive. If ERPR is positive, can we give tamoxifen? Is there a possibility? Yes, no, maybe. Possible, right? So ERPR positive, so I can have a hormonal therapy, not just chemotherapy, and well differentiated tumors. No P53. Obviously, type 1 has a better prognosis than type 2 endometrial tumors. Fine. Okay. Perfect. Now coming to gross features. We know the etiology, types, and the pathogenesis. And now we look at gross and microscopy. We already read gross and clinical features. Its endometrium has having a tumor. Okay. Imagine this is the normal endometrial cavity. You have tumors here. You have bulky tumors. You'll have polypoidal fungating mass into the endometrial cavity. Yes, obviously it can invade the myometrium also. Can find papillary findings in serous tumors. I'm having such amount of tumors proliferating and going into the cavity. Is there a possibility they can break and they can bleed? Can they? They will. So classical symptom is abnormal uterine bleeding. Please remember, tell this to your parents, mother, and also your sister. After attaining menopause, even a spot of blood is abnormal. They have to go and visit a doctor. Because after attaining menopause, it is a spot of blood, which means something is growing into the cavity, which can be a polyp, which can be cancer. Abnormal uterine bleeding, and the most important is this guy. Post-menopausal bleeding. Post-menopausal, it should not bleed. During menopause, yes, there will be intermittent bleeding. After attaining menopause, if it bleeds, it's abnormal, right? Pain can be there. Once it infiltrates outside the peritoneal, uterine cavity, ligaments and everything, you can have pain. Very advanced cases, fine? Okay, fine. So microscopy, you already know. Sorry. Management, diagnosis, we do an endoscopy, histoscopy, that's an endoscopy into the uterus. Cure it, take a biopsy, prove it. Diagnosed by default hysterectomy, plus or minus lymph node removal, and plus or minus chemo radiation based on the stage of the disease. You will read them when you go to gynecology. Fine. Okay. Now let's come to this guy. This guy is a new molecular classification, which is must for you to know, especially if you consider, if your exam university has more inclination towards asking recent advancements. Fine. Metro, endometriosis is benign. It is not behaving like a malignant disease. It's an ectopic rest, that's all. It is seen somewhere else. Like for example, I don't see squamous cell columnar epithelium in my esophagus. For that, I don't call Barrett's esophagus as malignant. It's a metaplasia, that's all, right? There is a risk of cancer. Here also there is a risk of cancer, fine? Let's come to this. The new classification is very important because it's purely prognostic. Till 4-5 years back, I have to report what is the microscopic type of the endometrial cancer. Now I don't want to do that. I take a biopsy, I look into the microscopy, I'll tell, yes, this is a cancer, this is not a cancer. If I say it's a cancer, then I'll send it to molecular genetics. If there are 4 types, one is pole, ultra mutated, where you have pole mutation. Pole is not something great. If you remember your first year, remember polymerase epsilon, DNA polymerase epsilon, that is pole. It's your DNA polymerase epsilon. That is getting mutated, right? Just DNA polymerase epsilon getting mutated, fine? Okay. So it will be endometrial high grade in morphology wise, but has an excellent prognosis. Is an excellent prognosis by default, right? Yeah, that is one of the theories, the benign metastasis theory, fine? So if pole is not there, then only you do the next step of MMR. If you remember your colon chapter when we discussed about Lynch syndrome and HNPCC. There also we read that, yes, this can also have endometrial cancer, right? That is this. MMRD stands for MMR deficient. MMR stands for methyl mismatch repair genes, right? The same MSH, MLH genes are deficient, muted. So microscopy can be any of these, but all of them will come under MMR, a decent prognosis. If MMR is not deficient, okay, and if pole is not there, then we have P53 abnormal, non-pole, non-MMR, abnormal P53, which is P53 mutated, right? Once P53 is gone, good or bad, that's the one which should have the worst prognosis, right? That's the one which has the poor or the worst prognosis, okay? Or I don't have any specific molecular subtype. I'm not able to find it out, or I don't have, the hospital does not have the technique or capability to do it, or the patient is not able to afford it. I keep them as intermediate prognosis. If I don't have anything, wild type means P53 is normal. Wild type is equal to normal. Wild type is not mutated, right? So that's the new classification. Pole hypermutated, MMR deficient, P53 mutated, and no specific subtype. If you remember this, that should be decent enough for you to write at least a 2-mark question or to answer in a viva if it comes there, fine? Okay, I'm zooming out. That's about your endometrial cancers, type 1, type 2, pathogenesis, etiology, gross clinical feature, microscopy, and also the new classification, fine? Done? Yes, perfect. Now let's have a quick look at ovarian tumors. See, quite a few universities do not ask ovarian tumors as a long answer or maybe short answer as well. But almost every university, every college will have teratoma as a specimen. They will ask you definitely describe this. You have to know something about that, right? Teratoma will be there. Definitely a big ovary will be there. Mucinous stadinoma or dysgerminoma, seminoma can come in an exam, right? So what we do in ovarian neoplasm we'll learn the classification, which can come in a viva, and also we'll learn few important germ cell tumors, teratoma, We read seminoma yesterday, cut copy of that is dysgerminoma. We look at yolk sac and one of the important sex-cord stromal tumors, which is granulosa cell tumor. Fine. Okay, let's go. We classify ovarian tumors into surface epithelium. See, ovary has an epithelium. Under that only you have follicles and everything, stroma, everything, right? Some from the epithelium, I can have tumors. Surface epithelial tumors are nothing but serous can be there, which is papillary. Mucinous can be there, fully filled with mucin, right? You can have endometrioid, looking like an endometrium. You can have clear cell. If you remember, I told for these two, the precursor relation is endometriosis. If there's an ovarian endometriosis long term, not taken care of it, you'll have to look at it, right? Yes, Raviraj. Classification is asked, but in detail, they may not ask you. Fine. Surface epithelial tumor, serous, mucinous, endometrioid, clear cell, and Brennus, right? Transitional, Brennus. We'll definitely look at classification, Maria. Okay. So they arise from the mullerian epithelium covering the ovary. This is the most common type of ovarian tumors. Germ cell tumors are not that common, but ovarian tumors, your epithelial ovarian tumors are definitely more common than germ cell tumors. We learn germ cell tumors more because of the age group in which they are affected. Fine. Like see, and all these now, all these 5 types, it's not just benign. If you want to write in detail, we have serous cystadenoma, borderline serous tumor, serous cystadenocarcinoma, mucinous cystadenoma, borderline mucinous, mucinous cystadenocarcinoma. For everything, we have benign, borderline, and malignant categories for all the surface epithelial tumor, right? So it's just benign. We have borderline. It's neither benign nor malignant, and we have malignant categories for all the epithelial ovarian tumors, right? Perfect. If you have time, you are bored not to know, don't know what to write in the exam hall, you can expand this 5 into 15. That's up to you. Or just put a mark slash saying that all of them have benign, borderline, and malignant categories. Fine. Next is germ cell tumors. Teratoma, dysgerminoma, yolk sac, or endodermal sinus tumor, choriocarcinomas. There are a few more as well. Embryonal carcinomas, not very common. Embryonal carcinomas are a bit more common in testis compared to ovary. Germ cell tumors are common to both testis as well as ovary, right? Dysgerminomas equivalent is seminoma and testis. That's all. Teratoma is same. Yolk sac is more common in the ovary, very less common in testis. Choriocarcinoma again more common in the ovary, very less common in testis. Fine. And they arise from the germ cells, occurs in children or young adults. Exception do stay there. Choriocarcinoma can be a little bit seen in an older age group also, but rest of them are the most common timeline is around 20 to 40 years. That's a reproductive age group type, right? Next is sex-cord stromal tumors, granulosa cell tumor and sertoli cell tumor, and we have one more guy called as fibroma thecoma variant. These come from the ovarian stroma and the cells in the ovarian stroma. Fine. These tumors can be functional. Granulosa can secrete estrogen, right? About choriocarcinoma, Raviraj? Sure, I'll do it for sure. Fine. They arise from the sex cord and the ovarian stroma. Fibroma is a benign tumor, just fibroblasts, that's all. Thecoma, along with that, you'll have the theca cells also. Theca cells can also be secreting, right? Granulosa cells will secrete estrogen, fine. Last but not least, never forget metastasis. Mets is Krukenberg. We have read about metastasis of Krukenberg whenever we read about breast cancer and your gastric cancer, right? So primary is usually from diffuse breast cancer or lobular carcinoma of breast. Can anyone spot a similarity in these two conditions? Anything similar between these two? Lobular carcinoma of breast and diffuse gastric carcinoma. Do you know anything similar here? We'll come to that soon. Krukenbergs are always bilateral. In Krukenbergs, the ovary shape does not change. It will be bigger, but it's of same shape, right? And they are mostly bilateral tumors. And the common denominator here is both of them will have E cadherin loss, right? That's why the tumor cells of the stomach are so dispersed, they can go to the ovary. From breast, so dispersed, they go to the ovary. And the mode of spread for both of them is CDH1 mutation. Yeah, you are right, Suhana. Your retrograde lymphatic spread. They are so dispersed, the cells can go in a retrograde fashion and they can go and sit in the ovary. Fine. Okay. So I understood CDH1 mutation. Fine. Ignore it. Okay. Perfect. So this is a simple classification of ovarian tumors. You have to read about them and Teratoma is something which can come in a viva because you will definitely see a sample of teratoma, right? Teratoma, one of the few questions they'll ask is the cell of origin, totipotent germ cells. If someone asks me, what is the difference between totipotency, pluripotency, and multipotency? Totipotency is the only germ cell which can produce all three germ layers plus extra embryonic tissue, which means it can produce even placenta. Placenta is not embryonic. Placenta is mother's maternal tissue, right? Totipotent germ cells can contribute to that also plus all three germ layers. My body has good amount of totipotent germ cells. One of the locations is gonads, testis and ovary. Apart from that, we have in the mediastinum, in the midline, sacrococcygeal. If you started reading a pediatrics textbook, there'll be a kid who will be lying down with a huge swelling attached to the gluteal region, sacrococcygeal teratoma. CNS in the midline I can have, we call them germinoma. All the midline structures, we have few germ cells which are just buried there. They can become teratoma, they can become germ cell tumors. Teratoma has mature, that is benign, immature, like borderline, and malignant teratoma. The most common variant is benign cystic teratoma, or you must have called them dermoid cysts. Benign cystic teratoma. What will be seen in gross? Cyst-like spaces filled with some sebaceous-like material, right? And the most important viva question will be, if there's a specimen, the solid area. There'll be solid areas in teratoma. We call them Rokitansky protuberance. Why it is important? When, as a pathologist, when I'm looking at a teratoma, I know it's a teratoma by looking at it. But I have to prove the microscopy. I won't go and keep on taking sections from all these places. I might get only epithelium. I'll go to the solid area. This is where the likelihood of me getting epithelium, mesenchymal, and endodermal cells are more. That's why the solid area is more important. That's why they come in a viva, right? Solid area is the place, Rokitansky protuberance is the place where I can see most likely all three germ layers. Easy for me to diagnose, that's why you have to know about it, right? And we have something called monodermal or specialized teratoma. Dermoid cyst is everything. Monodermal is one of the lineage is taking an entire go. That is struma ovary. Can anyone tell me what tissue will be seen more in struma ovary? That is monodermal or a specialized teratoma. In struma ovary, you'll have excess of only one tissue, that is thyroid tissue. Even the patient can present hyperthyroidism because they're secreting, right? They'll present hyperthyroidism, that's monodermal or a specialized teratoma. Then we have immature teratoma, which will have immature neural elements primarily. In other words, immature blastemal elements. Blastemal, how do they look like? Anything ending in blast, you know how they look like. What's the classical appearance in microscopy? It'll have small round blue cells. This also will have the same thing, right? The neuroepithelium will be immature, small round blue cells that we call as an immature teratoma. Immature teratoma is not benign, not malignant, in between. May not spread to the lymph nodes, fine. Last but not least, there's a possibility I can also have teratocarcinoma. Okay, teratocarcinoma is malignant. The most common subtype of teratocarcinoma is squamous cell carcinoma. The epithelium becomes malignant, which is squamous cell carcinoma, right? Perfect. That's about teratoma. I don't want marker to diagnose teratoma. It's purely on a gross and a histological diagnosis. Dermoid cyst, monodermal, immature, teratocarcinoma. Write about the origin, write about the location, if possible, draw a diagram composed of cyst-like spaces with hair going in here and there, fine? Okay, that's it. Seminoma, dysgerminoma, we know already. Is an ovarian counterpart of your seminoma, fine? Same, fleshy, cut potato appearance, very solid, no areas of hemorrhage or necrosis. This is the most common malignant germ cell tumor. I'm writing GCT for germ cell tumor as the most common malignant germ cell tumor. If there's a clinical history saying that this patient is an ovarian tumor along with hermaphroditism, the patient does not have a proper gender discrimination, along with that the patient has an ovarian tumor, think of dysgerminoma because it is very commonly associated with gonadal dysgenesis, right? Microscopy, we know, same. I'll have nests of tumor cells, nests of clear cells rich in glycogen, and the septa will have lymphocytes. This is classical finding for your seminoma, dysgerminoma, fine? Markers, same. CD117, OCT3/4 and SALF4 are the best markers. No, it's not malignant. It is predominantly benign, but there is a chance it can also become malignant. Fine. Teratoma is a benign tumor. Okay. OCT3/4, NANOG, and SALFO. These are the best markers for seminoma as well as dysgeminoma. Fine. I just want to specify this PLAP. I hope examiners will not use the term PLAP. PLAP is placental alkaline phosphatase, which was used to diagnose seminoma and dysgeminoma. The specificities and sensitivities are around 60%. No one uses it in real life, but still there are old questions which says PLAP positive tumor. If they ask, think of seminoma and dysgeminoma. Fine. Next is yolk sac. See, yolk sac, a tumor which is arising from intrauterine life, forming from intrauterine life, yolk sac. So what is the best clue? Age is the best clue. It will be seen in very young people. Less than 5 years, less than 10 years, ovarian tumor has to be yolk sac tumor. That is the most important clue here. Fine. Okay. They are solid lesions. Microscopy, one classical finding called Schiller-Dole bodies. They are glomeruloid bodies. So what I have is, I have a central vessel. Surrounding that, I'll have 2 layers of tumor cells. That's called as Schiller-Dole bodies or glomeruloid bodies. Fine. Alpha fetoprotein is a marker. One more marker is alpha-1 antitrypsin. Both of them are good markers in microscopy. And alpha fetoprotein is also a tumor marker in the blood, which you can use to diagnose yolk sac tumor. Nothing much to remember in yolk sac tumor. You will have the classical Schiller-Dole bodies, that is diagnostic of a yolk sac tumor. Fine. Last but not least, we look at granulosa cell tumor. Granulosa has 2 types, adult and juvenile. Can anyone tell me what does normal granulosa cell secrete? Whatever comes to your mind. What does normal granulosa cell secrete? They secrete? Perfect. They secrete 2 molecules. One is estrogen, the other one is inhibin. Right? Perfect. So if I have a tumor of granulosa cell, what will be the clinical feature? I'll have clinical features of hyperestrogenism. That's all. Now, in an adult, like a 30-40-year-old, hyperestrogenism will have endometrial hyperplasia and might have menorrhagia. But what do you think will be the feature in a child? Juvenile granulosa. I have excess estrogen in a child. What do you think will be the feature? You'll have? I'm sure you must have heard about this. We call them precocious puberty. The puberty hits, I think there's a definition for that. I'll leave it to the gynecologist, will be around 8 years or low, right? Precocious puberty, early onset puberty because of hormonal disturbances, right? So this tumor does not present predominantly with a abdomen mass. That will be there, but later, right? They are malignant tumors and they're estrogen secreting tumors. Adults present with a endometrial hyperplasia or menorrhagia, and children present with precocious puberty, which is early onset than normal because of excess estrogen in the person. And there's a specific mutation called FOXL2. It's a transcription factor seen predominantly in the adult, not seen in children. It's predominantly seen in adult and not seen in children, right? Now, gross finding of this tumor. See, the tumor might be tiny, can be ranging from 1 centimeter to 8 centimeter. Why it is important is, even a 1 centimeter tumor is severe enough to cause estrogen imbalance and produce symptoms. So I can go and diagnose the patient early, right? It is definitely unencapsulated, 1 to 10 centimeter mass. It definitely infiltrative mass. And one classical finding of granulosa cell tumor. What type of hormone is estrogen? Physiologically, how do you classify? Yes, Shwed, mitochondria is a powerhouse of cell. Physiologically, we classify them as what hormones? Is it protein? Is it, they are steroidal hormones, right? So if a tissue is secreting so much of steroidal hormones, will the tissue change color? They will be yellowish because fat, right? Yellowish tumor, 1 to 10 centimeter, infiltrative tumor is granulosa cell tumor. Fine. Microscopy, 2 named finding, both are important for me. Karl-Exner body, there will be 2 small follicle-likes with a central eosinophilic material, that is Karl-Exner body, and nuclear grooving. That's a coffee bean nuclei, which is very, very classical. You'll have a linear groove for a granulosa cell tumor, right? Marker, we know 2 molecules, right? Estrogen and inhibin. It will be positive for inhibin. In almost 100% of the cases, it will be inhibin positive. That's the way we diagnose granulosa cell tumor. Fine. It's malignant. It can metastasize by default. Okay. I'm zooming out. So we know the classification, which itself can come as a short note, and few other tumors. I hope they don't ask us an essay. They should be probably asking maybe Viva, 2 marks or short notes for that. Fine, perfect. So that brings us to the end of ovarian tumors. Now we're going to go to something which is not a hardcore part of your female genital tract, but there's a possibility it can come as a short note, which is gestational trophoblastic diseases, or at least you have to know about molar pregnancy. Molar pregnancy can come as a short note, or they might have a sample of molar pregnancy with hydatiform mole, right? The tiny grape-like clusters, as in the uterine specimen. That's a classical hydatiform mole, right? Okay. Can anyone tell me the number of chromosomes in a complete molar pregnancy and the number of chromosomes in an incomplete or a partial molar pregnancy? Krukenberg's Raviraj, 5 marks. First, Krukenberg is a ovarian metastasis. Krukenberg will not alter the shape of the ovary. Krukenberg's is bilateral. It originates from 2 common primaries, your gastric carcinoma, your lobular carcinoma of breast. Because of loss of E-cartin, the cells are loose. Instead of going normally lymphatics antegrade manner, it goes retrograde manner, and it will involve go and deposit in the ovary. And on microscopy, you can either see lobular carcinoma. What do you see? Linear Indian file pattern, or you have Signet ring cells. To say it's positive or negative, I can do an E-cartin loss, or I can do CK7 or estrogen to say positive or negative, and to know what cancer it is, right? See, every question, every answer, think for 5 seconds. You will have to fill these headings: definition, etiopathogenesis, gross, microscopy, markers. That's more than enough. Fine. Okay, 23. No. We'll look at it soon. Fine. So gestational trophoblastic diseases, here it's not only molar pregnancy. There's an entire spectrum where the placental tissues are proliferating abnormally. That's the definition of gestational trophoblastic diseases. One of them is molar pregnancy, right? So here, Asians are actually more prone for molar pregnancy and gestational trophoblastic diseases compared to other ethnicities. And extremes of age, a teenage pregnancy has more risk, and an elderly pregnancy around 40 plus again has more risk, because in both extremes of age, the ova is not accustomed to properly develop into a zygote. Very new makes error, very old makes error, right? These are 2: teenage pregnancy, elderly pregnancy, and Asian ethnicity increase the risk factor. We have 2 types of molar pregnancy: a complete mole and your partial molar pregnancy. Fine, both are hydatiform mole. Hydatiform looks like a hydatid cyst in gross. That's why we have the hydatiform molar pregnancy. Fine. Here, see, for me to have a zygote, the basic requirement is I need 46 chromosomes. Without that, a zygote cannot form. So what happens in complete mole is there is an empty ovum. Blighted ovum means empty ovum, no chromosomes, just the cover, that's all. No genetic material inside. And a sperm fuses it. Right? When a sperm enters this ovum, what will happen is it cannot become a zygote because I need 46 chromosomes. Okay? You need 46 chromosomes. You have 1 sperm or 2 sperms multiplying, having 46 chromosomes, which will be all paternal, and that is not compatible with life. Sure, Ravi. Okay? Abnormal villus, no fetal parts, will abort. A partial hydatiform mole, on the other hand, you will have an egg, which is, or an ovum, 23 chromosomes, plus 46 of the sperm. So it is triploid. The only place where human beings can have 69 chromosomes is your partial hydatiform mole. Here, I do a male component and I do a female component. Both are there. So I do form little bit of your fetal parts. That's why we call it partial molar pregnancy, because fetal parts will be there, but still it will die because 69 chromosomes cannot survive at all, right? So that's your complete and your partial molar pregnancies. Pathogenesis. Features, classical features: increased fundal height. Every age has a fundal height. If it is going beyond that, we call it increased fundal height, and you have a vaginal bleeding or spotting post-pregnancy and a very abnormally high beta HCG. 3 classical clues which are clinical features for a hydatiform molar pregnancy, partial as well as complete mole. Hydatiform mole can come as a spotter in your gross specimens. You will have classical grape-like vesicles. This is how hydatiform mole looks like. Hydatid cyst looks like tiny tender coconut bubbles. The same way it looks like that, right? Classical appearance is this, and fetal parts may or may not be seen. If it's seen, you have to think of a partial molar pregnancy. Fine. Great, Rishabh. All the best. Do well. Okay. Microscope, you have dilated villi, hydropic degeneration, right? Dilated villi. If there's a nucleated RBC seen, which indicates it's a partial molar pregnancy because of fetal tissue, right? Snow stop appearance is an MCQ which might come with a classical finding in your hydatiform mole in an ultrasonogram, fine. And obviously we have to follow up with beta HCG. How do I treat? This is an abortus. That's all. We do suction evacuation, remove it, throw it away, and the most important thing is you have to mandatorily follow up beta HCG. Someone asked me choriocarcinoma. One of the important risk factors of choriocarcinoma is a previous molar pregnancy because they are very, very, very tiny. Sometimes if I incompletely remove, some of them can stay back inside, keep on multiplying, dividing, and can become choriocarcinoma. Okay, 23 pairs. If you, I'll come to the Diksh. It's one sperm and that will reduplicate and become 46. Right? That's an androgenic duplication because 23 chromosomes alone cannot form a zygote. To form a zygote, we always have diploid and not haploid. Haploid is the gametes. Diploid should be the zygote. So one sperm only, it goes inside, duplicates and becomes 46. Fine? Done? Okay. That's about your molar pregnancy in short. Fine? So these... Okay. See, when compared to a complete molar pregnancy to a partial molar pregnancy, complete molar pregnancy has a higher risk factor to your choriocarcinoma compared to your partial molar pregnancy. For the only reason, see, partial molar pregnancy is a very unstable cell. It's a 69 chromosome cell. With or without treatment, if let's say a few of the cells are left behind, they will die automatically. They will not persist enough long term to mutate and become choriocarcinoma. For a cell to become cancer, for the cell should be stable for years because cancer pathogenesis happens for years, right? So it's a bit higher risk of malignancy in complete molar pregnancy compared to partial molar pregnancy for the only reason partial mole is triploid and they are very, very unstable. Clear? It's me? Okay. Welcome back. See you after a long time. Fine. So that's about your molar pregnancies. Fine. Okay. Then let's go to breast parenchyma. Just two things in breast parenchyma. One is simple short nose. Fibroadenoma phyllodes, these are both stromal lesions of the breast, and obviously the most important, your breast cancer. First you look at the breast cancer, then we'll come to fibroadenoma and phyllodes. Fine. Before going to breast cancer, can anyone tell me whatever comes to your mind regarding the risk factors of breast cancer? Whatever comes to your mind. Sorry. Risk factors of breast cancer. Breast cancer is important. You have to know them. In your second paper, it's criminal not to know breast cancer and going to the exam. It's something which can come very often. Come on, one risk factor. Raviraj, BRCA1, BRCA2, every mutation till now what I have said, syndromes are always second. When you write a cancer or any oncology related question, first always put the sporadic factors. Right? Perfect. Female gender, age, female gender, and any cause of hyperestrogenism, a firm, dense breast parenchyma, which means it is equivalent to saying more estrogen is there. That's all. More estrogen, always risk. And obviously, undoubtedly, BRCA1, BRCA2 mutations and other mutation-related cancers as well, right? Perfect. Can anyone tell me what will be the history of breast cancer? Apart from hard mass, hard irregular breast parenchymal mass in a 50-60-year-old person. Apart from that, do you know any specific keywords for the history of breast cancer? Any specific keywords? Nullipathy is definitely one of them, right? So you have the purely orange appearance, that's one. A question which says bloody nipple discharge, that also is one of the important clue, right? And if the question says there is itching and discharge in the breast, think of Page's disease of breast, right? Think of that as well, right? History with respect to breast cancer tumors, fine? Now let's look at one by one. Breast cancer is by default the most common cancer in the world, obviously the most common cancer in the women as well, fine. Sporadic risk factors, Robbins and WHO divides them based on the relative risk. RR stands for relative risk, which means an old female, that's all, increased age, female gender, has 4 times more risk than a male of the same age group. That's enough, right? So this increases the risk 4 times compared to a normal population. And a high breast density, which means more estrogen and first degree relatives. That's where your syndromes, everything comes here. Moderate risk, any radiation exposure or high penetrance gene mutation. We'll look at the gene mutation soon. Radiation exposure, if you have a Hodgkin's lymphoma or any thymic lymphomas, they'll give radiation here, will affect the breast. Esophageal tumors, they'll give radiation here, which will affect the breast parenchyma. Right? In the field, anything will affect, lungs will affect, by default, that's a moderate risk. Low risk is all the cause of hyperestrogenism. Early menarche, late menopause, nulliparity, obesity, not breastfeeding, alcohol. The common denominator here is you have hyperestrogenism. Okay, that by default can result in a breast cancer. Fine. Okay, syndromes. There are multiple syndromes. The basic few things, at least, which I want you to remember is BRCA1 and BRCA2. Because BRCA1 and BRCA2 together occupies the 90% of the inherited cancers. In general, the syndromes or inherited risk factors of the latest report, 2/3 of breast cancer is related to syndrome. Nulliparity means not giving birth to a kid during the lifetime of the women. Fine. Great question, Sai. Meaning of sporadic risk factors means, if I say this is sporadic risk, which means anyone in this world can have the disease. Any woman in this world who's older is at risk. Any woman in the world who has radiation exposure is at risk. Syndromic means that family inherited, right? That's the meaning of sporadic and syndromic. Sai, you are at risk of getting an upper respiratory tract infection like me. There's no difference in risk between you and me. That is a sporadic risk factor. Fine. Let's come back to this. BRCA1, BRCA2, two basic things which I want you to know. Both BRCA1 and BRCA2 are involved in DNA repair mechanism in a complex called as FAN complex. The same complex which affects Fanconi anemia. So in BRCA1 and BRCA2 is not there. What primarily happens is the DNA repair, especially the chromosomal repairs, will go bad. If the chromosomal repairs goes bad, you end up in accumulating more mutations which causes cancer. Same like methyl mismatch repair gene, but in terms of chromosomal repair. That's what BRCA1 BRCA2 pathogenesis is, right? We have them in these chromosomes 14 and 13. If you can remember, great. Otherwise, ignore them. Triple negative BRCA1 have to remember because that's one of the worst prognosis, right? These are ER positive tumors. Male breast cancers is a little bit more common in BRCA2 compared to BRCA1. BRCA stands for breast cancer 1, breast cancer 2. That is BRCA1 and BRCA2. Fine. In addition to breast, you have ovary, fallopian tube, prostate. Here also you have ovary, fallopian tube, and like I said, Fanconi anemia. If you have two mutations in BRCA very early in life, can have Fanconi anemia. By default, BRCA has poor prognosis, 1, because of the mutation. Triple negative, right? It's not hormonally responsive. BRCA2 compared to BRCA1 is a better prognosis. I'm not saying it's great. That's a better prognosis compared to BRCA1 mutation, right? This, like I said, this is around 55% of the breast cancers. This is around 35% of the breast cancers. Okay. There are few more inherited cancer syndromes. One of them which I don't want you to forget, CDH1 mutation related. Hereditary lobular carcinoma of breast. You can have P10, which can cause. You can have Peutz-Jeghers syndrome, which can cause. Okay. How can you forget Lee-Fromley? Lee-Fromley can cause. Fine. All these are cancer syndromes which are like 1% or 2%. 90% BRCA1, BRCA2. If you write that, more than happy, right? Perfect. So what will be the history? History, like I said, you already know if there's a family history that's different. Otherwise, the age group is around more than 40-50 years. Family history might have less than that, but generally in old age group, you have a firm irregular mass in the breast parenchyma, bloody nipple discharge, and like you guys said, the blocking of the lymphatics and everything, the purely orange appearance, retracted nipple, irregular destruction of the nipple, all of them are suggestive of breast cancer. Plus, if there's an extra lymph node involvement, that also helps to, axillary lymph node helps in the diagnosis, fine? Okay. So we know a little bit of the etiopathogenesis and about the clinical features, right? So now, what are the types? See, breast cancer, before going to breast cancer, we need to know the same sequence like we said for cervical. CN 1, 2, 3, then cervical cancer, right? Like that, breast cancer also has something called an in situ lesion and cancerous lesion, right? So we'll look at in situ lesion first, then look at cancerous lesion next. So here's something called an ductal carcinoma in situ. This is like a precursor to malignancy. This also can be detected and this also can be treated, right? So here, malignant clonal population, but they are limited to the ducts by the basement membrane, which is there is no basement membrane invasion. It's an in situ lesion like any other lesion. How can I pick up them? Mammography shows microcalcifications, because one of the common ones, VHL not that much, right? One of the common ones which causes a type of DCAS is something called an comedonecrotic DCAS. Whenever there's necrosis, you'll have calcification, and that can be picked up by your mammogram as microcalcification, right? Comedonecrosis, which means the entire center part will have necrosis. Along with that, there can be calcification in the microscopy. That's the one can be picked on a mammogram. Very classical finding, right? That's a common variant, high-grade variant called comedonecrotic DCAS. Then we have something called cribriform DCAS. The same cookie cutter pattern or a cribriform pattern has a good prognosis. We have papillary, we have micropapillary DCAS. Okay, which means the pattern is different. You'll have tiny papillae with fibrovascular growth, micropapillae without fibrovascular growth. Whatever may be the morphology, one important thing is the basement membrane should not be breached. Can anyone tell me, with respect to the yesterday's class, we talked about and we found a similarity between breast and prostate. What is one of the important layer should be present in order to tell me that, okay, basement membrane breach has not happened? It's me. See, if it's equal stage, equal clinical prognosis, equal comparison of BRCA1 and BRCA2, BRCA1 has a poor prognosis compared to BRCA2. Okay, if you ask me based on the timeline, how good and how bad, that's based on multiple parameters that can be only individualized based on the patients, right? Perfect. The myoepithelial layer. Ductal carcinoma in situ, when I say no basement membrane breach, which means they will have in microscopy, apart from this pattern, the most important thing is a preserved myoepithelial, M is myoepithelial layer, and like you guys said, it will be positive for P63. That's the most important thing for me to say. Okay, it's a in situ lesion. It is not an invasive lesion. So how can DCAS present apart from this? See now, little bit if you go back, this is my duct, this is my lobule or the terminal duct lobular unit. I have a tumor here which is not going outside. Outside means it's not going here. That's what invasion, right? So can it go here? It can. So the DCAS, one of the outcome, yes, it can produce a mass, vague irregular mass. Other outcome is it can spread via the duct, go to the lactiferous sinus and go to the nipple areola complex, which means it can become Paget's disease. Paget's is a spread pattern of DCAS or an underlying IDC. I can have a cancer below it or I can have an in situ lesion below it. Here it is Pagetoid spread of the breast cancer. It's spreading along the duct and going into the nipple areola complex. It produces an exact eczematous rash, like an eczema, which will be itchy, will have tiny discharge, will have tiny scarring, right? How do I see in microscopy? You will see large atypical cells in the epidermis. Nipple is squamous epithelium, right? See you next year, Ishwar. It's a squamous epithelium, and the large atypical cells inside the squamous epithelium is diagnostic of Paget cells, and I want you to remember that. But there is a problem here. Paget cells have clear cytoplasm. Eczema is a chronic condition, that is, will have macrophages that also will have clear cytoplasm. We call them Toker cells. The way to differentiate them is these Paget cells are HER2 positive or they are CEA positive, right? If at all have a diagnostic trouble, I'll do HER2. If it's positive, they are Paget cells. If they're negative, they are macrophages, and my diagnosis is different. Fine. Pages of nipple can come as a 2-mark question if university has that, or can be in a viva. Fine. Okay. It is irregular atypical clear cells in the epidermal layers of the nipple, which is due to an underlying breast cancer or an underlying DCAS, right? Then we have IDC. IDC is the most common type of cancer. In that, IDC NOS, not otherwise specified, is the most common microscopic subtype. We grossly divide them into IDC NOS, lobular. Then we have special types. We have special subtypes of IDC, which has different compared to no other special type. Fine. So here, grossly, IDC is also called a serous carcinoma. When you cut a breast cancer, you will have that sound, like it'll feel like you're cutting a stone or cutting a calcified lesion. Because breast cancer has so much intense desmoplasia, it'll be very, very hard. That's why it's the term serous classification, right? And we use a classification score called as Bloom-Richardson classification, which helps us to classify the grades of IDC. We have 3 grades of IDC: grade 1, grade 2, and grade 3. Normal breast cancer, normal breast epithelium is not positive, but these tumor cells, Paget cells are positive. Normal nipple areola squamous epithelium is also not positive for hertonium. Fine. Okay. So it's based on tubule formation, nuclear grade, and mitotic count, right? Microscopy of IDC, you will just have infiltrative tubules. Tubules are nothing but tiny ducts, tiny glands. That's what it's. Same 4 features will be there. Pleomorphism, high N ratio, mitosis, loss of polarity. Based on the number of tubule, the grade of nuclear pleomorphism, and mitotic count, based on Bloom-Richardson classification, we have grade 1, 2, and 3 for breast cancer. This is a histological classification. No special type. I do have special types also. We have something called mucinous and colloid. Mucinous or colloid cancers, it will be full of mucin with very few tumor cells. It will be lakes of mucin with floating tumor cells. Very less tumor. Only mucin is more. Obviously, that's good prognosis. Tubular cancer, cribriform cancer. Tubular cancer will have more than 90% well-formed tubules. Very less pleomorphism. Good or bad? Obviously good, right? They are very good, very well differentiated tumors. Cribriform, same finding. You'll have the cookie cutter appearance. Cribriform DCS is also good for us. Cribriform IDC is also good for us. Fine. They also have good prognosis. Medullary carcinoma. What does medulla mean? I've told this multiple times in our classes as well. Medulla means soft. Okay. See, the word medulla is very important for us to differentiate few things. Medulla means soft. Cortex in the bone, medulla is soft. Any term where I use medullary carcinoma, these are not hard cancers like we used to see. They are soft cancers. So why are they soft? Hardness of a cancer comes from infiltration. So they are soft cancers. The first word is enough for me. They have pushing margins. They don't infiltrate. They'll push and go. Only when I infiltrate like this, I'll have reaction and desmoplasia. Rather than I push and go, I won't have desmoplasia. Then I have sheets of tumor cells, no tubule at all. So which means differentiation is the worst. If it's a tubule, looks like breast. Sheets of cells, it doesn't look like breast. And you have dense lymphocytic infiltration. And they're often triple negative. Good or bad? What do you think? They're definitely bad prognosis. Because they are soft, diagnosis also slightly might be a little bit later. The patient might not much worry, not hard mass, they'll not much worry. It will not go and infiltrate the nipple areola complex, will not alter the nipple, they won't come to us early, right? Pushing margin, triple negative, dense lymphoplasmatic infiltration, sheets of tumor cells without differentiation, all confers bad prognosis for medullary carcinoma of breast, right? Last but not least is inflammatory breast cancer. Actually, it's a clinical diagnosis. In microscopy, it is same IDC. There's no inflammation in inflammatory breast cancer. So someone said that there'll be lymphatic obstruction, right? Imagine I have a very high grade IDC, which is kind of involving all the dermal lymphatics. It's going and blocking every dermal lymphatics in the precordial breast region. It's blocking everything. If it blocks everything, is there a possibility I can have mild swelling? I can have mild swelling without fail, right? You can. So if you have a mild swelling and it'll be red, because it's not, the flow is not there because all the tumor cells are blocking there. Whenever tumor cells block, it will release a little bit of inflammatory cytokines. That's what tumor cells do when they undergo metastasis, right? This is also kind of spread only. So they'll block, they'll irritate, clinically looks like a red warm breast. Whenever it's inflammatory cancer, it will automatically upgrade itself to stage 4, T4. In the staging, it's a high-grade IDC, which is involving the dermal lymphatics diffuse, not in one place. The entire place involved, they'll be swollen, red, and tended to touch. That's classical for an inflammatory carcinoma breast. Like Ruber-Kaller tumor of inflammation, it is seen there. So we call them a misnomerous inflammatory carcinoma. There's no inflammation in the microscopy. It's pure blockage of dermal lymphatics. Fine. It is. I just explained inflammatory carcinoma. See, Nottingham scoring system, Bloom-Richardson is a better scoring system, which is followed. The older one was a bit of Nottingham. You can write Bloom-Richardson for Nottingham. Nottingham is something which is used for DCAS. DCAS scoring system for undergraduate, not that much required. Fine. Lipomas and adipose tissue tumor, right? Nothing much to worry about it. Benign lesion, don't worry about it. It will automatically come back to normal. If it's disfiguring, remove them. That's all. Okay. Then is infiltrating lobular carcinoma. CDH1 loss, classical. Because of CDH1 loss, the cells are dispersed. So bilateral tumors are possible. Multicentric tumors are possible, right? They won't have a hard mass. Instead, they'll have vague nodularity because they are dispersed. They cannot form a mass. Microscopy, the classical finding is Indian file pattern, where the cells go one behind the other, like red Indians. Indian file pattern, there will be no tubules. They cannot form tubules because there is no adhesion at all. Single file cells. And E-cadron is negative. It's important. In IHC, always we look for positivity, right? Here we look for negativity. If it's negative for E-cadron, I know that CDH1 is lost, so it's diagnostic of an invasive lobular carcinoma. Fine. In ductal carcinoma, E-cadron will be positive. These are also ER positive tumors only. The prognosis early stage is better, but later stage, because of metastasis, the prognosis drops. Because like we just now read, this can become Krukenberg's tumors and can go and involve them as well. Fine. Perfect. Whatever tumors in the breast we do, we have IDC, special type, no special type, invasive, whatever it is, we need to molecular classify breast cancer and only then treat. The best way to do molecular classification is protein expression assays, gene expression profiling, but that's not possible in real time. So what we do is, we do a cheap man's thing, which is immunohistochemistry. We do markers of ER, PR, HER2/neu and Ki67 to tell, okay, whether there's a luminal A, B, HER2/neu enriched or basal-like. Simple 4 things. Okay. ER, PR positive, HER2 negative, low Ki, which is less than 14. It's luminal A, the best prognosis. ER, PR positive, okay, HER2 with high Ki or ER, PR, HER2 all are positive. Both are luminal B. ER, PR positive, HER2 negative, but Ki is more than or equal to 14%. That's what high Ki is, right? Or all 3 are positive. Then I call it as luminal B. They have a good prognosis. This is ER, PR negative, HER2 alone is positive. It's better if they can be given a trastuzumab therapy, which is antibodies to HER2/neu. Otherwise, the prognosis is not great. This is a bit expensive drug, but if you can give that, yes, it's possible. Third is triple negative, which is ER negative, PR negative, HER2 negative. One of the worst prognosis, because here we can do IBC, we can do only chemotherapy. We can give cisplatin based chemotherapy here. Hormonal therapy will not work here. So obviously the prognosis is worst. Fine. Okay, got it? Fine. So the HER2/neu scoring has gradations. HER2/neu is what is Ki67? Ki67 is a marker which is a proliferative index. Fine. So if a Ki67 is positive, the cell is dividing. That's what we mean by proliferative index. Fine. If 14% means 14% of the cells in the tumor is proliferating. That's what KS is 14% mean. Fine. Coming back to this, IHC of HER2/neu, if it's 0 positive or 1 positive, we call them negative. If it is 2 plus, we call them equivocal. Okay. If it's 3 plus, it's completely positive. This patient is eligible for trastuzumab, or this patient is eligible for Herceptin, right? That is 3 plus for HER2/neu. But what happens is, sometimes when you get 2 plus, when I call it equivocal, I don't know what to do. All HER2/neu 2 plus should be followed by HER2/neu fish, because this is cat on the wall. If it's 2 plus, which is ambiguous, we have to perform fish, and then based on that, we will be able to take a call whether it's positive or whether it's negative. Fine. Okay. Got it? Okay, for lobular carcinoma, fine. See, for lobular carcinoma of breast, they are ER positive tumors, but again, they have a good prognosis without fail. Early onset is good prognosis. Prognosis of lobular cancer is a bit dicey because there are two terms used for lobular carcinoma or any cancer prognosis. They are ER positive tumors, they are hormonally responsive tumors. Maximum they can be luminal A or luminal B. They will not go beyond that. Fine. And they have good prognosis. There is something called long-term disease-free survival. See, for every cancer, we have two parameters. One is 5-year survival, then long-term disease-free survival. 5-year survival is amazing for lobular carcinoma because it's early. I can give hormonal therapy, they respond very well. But a long-term disease-free survival, what happens is, over the period of time, when they start spreading outside, going to the lymph node, going to the ovaries, prognosis drops. Long-term disease-free survival is less for lobular carcinoma, but a short-term survival, 5-year survival is very, very good for lobular carcinoma. Fine. Okay. Perfect. And one of the most important clinical feature to which determines the prognosis of breast cancer patients is lymph node metastasis. If the person is having lymph node metastasis, prognosis drops drastically. If the lymph nodes are free, prognosis is definitely better. Like I said, the Sai to Dukshu who asked, Ki is a proliferative index. It tells whether the cell is in mitosis or not. That's all. The next step is simple. If IHC score for HER2/neu is 2 plus, I have to do FISH on the same sample. Based on the FISH scoring, we will determine whether to put it to 3 plus or whether to put it as negative, since it's equivocal. Fine. Okay. That's in short about breast cancer. Just to complete breast, we look quickly at fibroadenoma and the phyllodes. You know many things about fibroadenoma. I need not talk more about that. Most common breast benign tumor, 20 to 40 years. They are very, very, very mobile tumors. They are dubbed as breast mouse. Don't use the term breast mouse. Just call them highly mobile tumors, not attached to the surroundings. That's all, right? MET12 mutation is a new mutation which is seen in leiomyoma of the uterus, phyllodes, as well as in fibroadenoma, right? Because of MET12, there's a proliferation of both intralobular glands as well as stroma, right? The stroma will become compressing the duct. Since the ducts are softer than the stroma, duct gets closed as a slit-like space. That's what we see in the gross as well. You see slit-like spaces. And when you do an FNAC, the same slit-like spaces are pulled outside. So I have like an antler horn. These are nothing but the clustered, tightly coherent epithelial cells, and in the background we'll have bare nuclei, which is nothing but the stroma. An antler horn appearance with a very cohesive epithelial cells. It's diagnostic of fibroadenoma, and obviously when you do a biopsy, you will see both, and proliferation of the epithelium as well as proliferation of the stroma with compressed ducts. That's fibroadenoma. The pericanalicular, intracanalicular variant doesn't matter much for the prognosis. Ignore them, right? Why mobile? It's simple, no, Ravi? It's a benign tumor. No benign tumor will have capsular invasion. It is well defined. Only see, this is a tumor, this is a surrounding tissue. Only when this tumor infiltrates into the surrounding tissue, it will hold the tissue, right? Only then it will not move. That's a feature of cancer. If it's not invading the surrounding tissue, it will automatically move. Lipoma moves because it does not invade and go outside. Any benign tumor for that factor moves, not just fibroadenoma. Fine. Okay. There's a term called as complex fibroadenoma. The only reason to know this is there is 1.2 times more risk of cancer in this patient on a long-term follow-up. Very, very less, but it's worthwhile to follow up this patient, right? When fibroadenoma says cyst, they're generally completely solid tumors. Or if there is sclerosing adenosis, or if you have epithelial hyperplasias, this epithelium is generally not hyperplastic, it's compressed, that's all. I'll have more glands, but not more layers of epithelium, normally. Epithelial hyperplasia, calcification, all these suggest complex features. These patients should be kept on follow-up. Don't scare the patient that they'll have cancer, but it's very wise for us to keep the patient on follow-up. Diagram, you want me to draw a diagram. I'm worst in diagram, but I'll still try. Fine. Phyllodes tumors. Phylloid is also a stromal tumor. One of the classical clues in real life, 10 plus centimeters of tumor in the breast parenchyma has to be phyllodes and not anything else, not even breast cancer. Fine. Here it's me. Gross is this. Firm nodular slit-like spaces. FNAC is this. Antler horn appearance. Cohesive epithelium and background your bare nuclei. Got it? I'll draw the histopathological section soon, Ravi. Fine. Here also you'll have metol mutation, and telomerase mutation is commonly seen in malignant phyllodes. Phyllodes is benign. Phyllodes has benign, malignant, and borderline. I think I answered most of your question. If you missed anything, do let me know. Fine. Okay. So grossly, phyllodes have something called a cut cabbage appearance. They are more fleshy. I don't know if it looks like a cabbage. That's what a classical name is. Phyllodes has leaf-like pattern. More than that leaf-like pattern, what I'm more interested in is stroma. See, the stroma grows too much. And I do have epithelium also. But since the stroma grows too much, the corner of the leaf alone will have epithelium. Rest of the base of the leaf will have stroma, right? Stromal overgrowth is classical for fibroadenoma. Sorry, classical for phyllodes. But in fibroadenoma, I'll have both stroma as well as epithelial overgrowth. But here, stroma takes an upper hand. That's why I have the classical leaf-like pattern. Fine. Okay. Phyllodes, the way to treat phyllodes is you do a surgery. But the only problem is because of the infiltration, they can recur a lot. Recurrence is one of the biggest concern for phyllodes because they're so huge. It's impossible for you to remove every tiny bit of the tumor, so they'll come back, right? And obviously they can, most of them are benign. They do become malignant phyllodes as well. When they become malignant phyllodes, they are primarily sarcomas, as simple as that, right? Okay, your question, Ravi. See, if you have to draw a feature of fibroadenoma, any microscopic diagram you draw, please don't put a big circle or a big square. Make it as small as possible so it's easy for you, right? First, draw the stroma. It's a stroma and epithelium rich tumor, right? So draw the stroma, leave some gaps between the stroma, and the gaps are the one which will have the compressed ducts. The compressed epithelium, the compressed epithelium, the compressed epithelium. You can draw in any different way the compressed epithelium. So you can say this increase in the stroma, that will be there, and also you'll have the compressed epithelium that is classical for your ducts, or epithelium is classical for your fibroadenoma. Fine. No, these are stromal tumors. See, you cannot give a hormonal therapy for fibroadenoma or phyllodes. Fibroadenoma is excision, phyllodes is excision, and base you can give radiation. I don't give a hormonal therapy for that. Fine. Okay, fine. So that's with your breast and the female genital system. We have come to the end. If you have any doubts, do let me know. I'll have 3 sessions on general pathology. We'll complete general pathology. After completing general pathology, we'll take care of the rest. I think my general pathology sessions will start after a break of a week or so, in and around Independence Day. And before that, please complete all the hematology and systemic pathology. Sure, Ravi. I need one more day for it. I'll definitely ask them one more day, in between squeeze somewhere and complete the tiny bits of systemic pathology as well. Sure, I will try to do that. Okay. Any doubts? Do let me know. If not, let's call it a day. Thank you guys. All the very best. Thank you for your time.